Another high-yield subject for you guys is pericarditis. We've already seen it multiple times in this section, so you better believe you'll probably see it multiple times on your test. This is a very important disease because recognizing it in your patient could also potentially save their life and your medical license. So, step one is for understanding fundamentals behind how diseases kill people and then how you can prevent that from happening. Let's quickly just visualize what we're talking about when we say the pericardium again. So we have our fibrous parietal pericardium represented by the F, and then we have our visceral serous pericardium because it secretes a serous fluid. Within these two, this is our pericardial sac. Directly under the visceral serous pericardium will be our myocardium. And remember, the epicardium and the visceral layer of the serous pericardium are sometimes referred as the same thing, but there's actually a little bit of a distinct layer there. So be careful with that. So, this is our fibrous layer of our pericardium, visceral layer. The epicardium itself, where the coronary arteries run, is very contiguous with that visceral pericardium. And then we have our myocardium and then our endocardium. So there are multiple layers to the pericardium, the fibrous and the serous. So the epicardium is composed of the visceral serosal layer that is adherent to the myocardium. It encases the entire heart, and at the level of the pulmonary trunk and aorta, this double-layered serosal layer kind of folds back on itself like a tortilla, as you can see here. So the gray vessels will be exiting the pericardial sac. So this will be the pericardial sac here, and the gray vessels are not enclosed in. So note, these vessels here, leaving this pericardial sac, are not enclosed in pericardium. So the outer layer of the tortilla that we're talking about again. So this is our tortilla folded over at the level of the gray vessels. This is the aorta going out, and then this is the pulmonary trunk. This is the fibrous layer of our pericardium, and this is the visceral serous layer. Directly in between these spaces and directly above the visceral pericardium surface is the pericardial cavity. And this is normally filled by a serous-like fluid that is produced by the visceral serous cells. These are mesothelial cells. Your Step 1 book talks about a fibrinous, a serous, and a suppurative or purulent pericarditis. A fundamental couple of things should be reviewed here before we discuss the inflammation of these pericardial layers, which we like to call pericarditis. So number one, because this is inflammation, it is just like all other inflammatory processes, in which there's a fundamental concept that you can think about to reason through it, which is disruption of endothelial cell intracellular adhesions. So for example, when we're talking about transudation, there is just a disruption of the leakiness of the endothelial cell barrier. So transudation is usually capillary leak that leads to protein and fibrin to leak across the cell endothelial cell barrier, followed by neutrophils and macrophages, initially monocytes, but will convert to macrophages when they hit the tissue. These leukocytes release cytokines that cause fever, pain, and a fibrotic-like response by fibroblasts. Now, what are we talking about when we say suppurative or purulent, which means that there will be pus, right? It makes a lot of sense because neutrophils are going to invade the pericardial cavity, trying to go after some organism in there, and dead neutrophils make pus, and that is how you can get a purulent or suppurative pericarditis. Now, bacteria can be the main problem. The main culprits for this are the Streptococcus species. Bacteria can access the pericardial cavity from a pneumonia, so a direct extension, right? So pneumonia. How else can bacteria get into the pericardial cavity? Hematogenous spread, so via the blood, via the lymphatics, or a direct extension via an operation, so an OR. What about this serous pericarditis? What is that talking about? What does serous mean, first of all? So the mesothelial cells that line the visceral layer of the pericardium on this side, so these mesothelial cells, which you also see in the pleura of the lungs. So these mesothelial cells secrete a very lubricating fluid that is called a serous. Obviously, that's why this is called the serous pericardium, because that's what these cells are secreting. Now, in the serous pericarditis, there is excessive amounts of serous fluid accumulating. So way too much fluid accumulating in the space between the serous and visceral pericardium. In the situation here, there's usually no bacteria and a very low amount of inflammatory cells. So without a very low amount of inflammatory cells, there's not going to be very much pus. This is why it is not called suppurative. So somehow our immune system is basically activating some sort of immune response without any bacteria present. Most of the time, classically, serous pericarditis is after a upper respiratory viral infection. So a viral URI. It can also be associated with rheumatoid or lupus. So maybe some sort of antibody component, right? You can make antibodies against viruses. There's definitely antibodies circulating around in rheumatoid arthritis and as well in systemic lupus erythematosus. So just way too much fluid here, an inflammatory component causing inflammation of the pericardium, in addition to way too much serous fluid being generated due to activation of the mesothelial cells that compose the visceral pericardium. Now, on the other hand, fibrinous pericarditis is caused by, classically, the post-infarction immune response of Dressler syndrome. Remember, this is when cardiac antigens are processed by our immune cells, and then they respond with an autoimmune attack due to generation of antibodies against cardiac antigens. Some other things that can be associated with fibrinous pericarditis is uremia, in addition to post-radiation fibrotic responses by the pericardium. So, in fibrinous pericarditis, you would expect to see a very rough, sandy-looking pericardium, right? Because fibrin, hence the name fibrinous, protein, and a lot of inflammatory cells. So let's talk about neutrophils and potentially also some macrophages get caked onto the levels of the serous and fibrous layers of the pericardium. So again, there's just a caking of fibrin here all along the fibrinous parietal pericardium and the visceral serous pericardium. If you accumulate a bunch of stuff in here, there's going to be a very thick layer of stuff. Now, some textbooks have described this accumulation of stuff, protein, inflammatory cells, and fibrin as a piece of toast with a thick layer of butter on top, stacked on with another piece of toast with a thick layer of butter on top, so that you can actually get these two layers stuck together. As you can imagine, if you rub two pieces of toast together and then you try to listen to that with your stethoscope, you're going to hear a significant rub, right? And this is the classic finding on the cardiopulmonary exam, is the friction rub, because these two layers are swollen and full of inflammatory exudate, and fibrin is accumulating here, and you get this friction rub between these two layers that are normally separated by a clear, low protein, low fibrin, serous-like component of fluid, right? So, obviously, wherever there's inflammation and rubbing, the nerve endings within these pericardial layers are sensitized, and they sense pain every time these two layers move, which is every time the heart beats. And that is the basis behind this pleuritic chest pain that we talk about with a pericarditis. So pleuritic usually means talking about the pain associated with the movement of an irritated lung pleura. And this is a misnomer. The pleuritic chest pain that you see in acute pericarditis is not due to any sort of irritated lung pleura. Remember, because nothing is wrong with the pleura of the lung in pericarditis. The thing is that when you breathe, you expand all structures within the thorax due to the increase in intrathoracic negative pressure. So breathing in will also expand the pericardial cavity, because it is also under this newly introduced negative intrathoracic pressure. And that is the basis behind the pleuritic chest pain that you see in a pericarditis, because those inflamed layers of the pericardium are going to be even more irritated when they get expanded. Now, what about the ECG? What would you see on the ECG? The classic ECG pattern is you get ST segment elevation or PR segment depression. So, ST segment elevation diffusely, right? Because the entire heart is involved. Pericardium can all be irritated. And then the PR segment depression is a very unique situation that you should look out for in the sense of pericarditis.